Both online as well.
Sorry, I got stuck at work
Introductions
fixing
around
a
the
server
table.
blade.
Chris?
I do not.
Yeah, Nico Hash, Lewis and Clark County Attorney's Office.
Nice to meet you.
Nice to meet you.
Hi, Becky Doctor, City of Helena City Attorney's Office.
John Campbell, Fire Chief.
Tim Burton, City Manager.
Andy Coyle, ER Doc.
And I'm Ann McCoy, Director of Critical Care from St. Pete's.
And Chris Mulberry, I'm the new EMS manager for St. Pete's.
And I'm Stephanie Crick. I'm the admin for the fire department. Chair Stephanie.
It appears we have a quorum, so we can move forward. We sent out in the meeting packet some of the things that we had worked on last time, the update to the bylaws and so on, as well as the minutes. Any discussion on the previous meeting minutes? Do we need a motion to accept those?
So what is a quorum? What is
Four.
necessary?
For the voting
1,
members.
2, 3, 4. Yep.
Yeah,
Okay.
quick math.
Sorry, I just wanted to make sure. I
No,
move to approve the minutes.
I'll second it.
any discussion? All in favor, say aye.
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 Hi.
Carries unanimously. Thank you. Presentation of the ambulance company report from 2024. Mr. Mulberry, that would be you.
Oh, I apologize. I didn't bring it with me.
We've got it up on the board.
Here, and I've got a copy right here that you can look at.
I looked at the previous kind of report that we had, so tried to expand on that a little bit and give a little more data. With what I could pull, with the explanation having there that unfortunately the data that we have up there isn't the cleanest because I have unfortunately multiple sources of truth with the way that where we document some of the things. So in the process of changing that, so moving forward, we're only gonna have one. So I will have cleaner data to present with as far as, because like if we didn't transport anybody and we didn't do much of anything, it was documented in one place. Blood draws were documented in another place, and then medical transport type things were documented within image trend. So trying to clean all that up so we have one, so we have better data. So the data that's in this report is all from with what we have with image trend, which is our primary for our patient care reporting type of software. Knowing, we understand it's not quite the most accurate, the numbers are going to be lower as far as total number of calls. This does capture all transport data from everything that we do. So, and then a little bit of the breakdown, how we haven't changed anything major operation wise with how we function, other than trying to improve our staffing at the moment. So looking at total number of calls that we have documented in trend, we did 7,305, with the bulk of them here in Helena, obviously, with the population. Then looking at some of the other things like our busiest time of day is from about noon to about 3 o'clock. So we run the bulk of our calls. And the middle of the week is basically the busiest. Tuesday, Wednesday, Thursday, with Sunday being the slowest day of the week.
I'm just curious, but do you have a sense why noon to 3 o'clock is the busiest? Or is it just the way it works?
Probably it's when most people are most active, would be my guess. Because even people like to stay up late, that kind of thing, they're up and people are already during the day, busy, moving around. I mean, that would be kind of my guess as to why. But the system I came from was relatively similar. It was like the early afternoon typically seems to be very busy. It would fluctuate a little bit. Like another system I worked in where we had like some more bars and nightclub type of stuff where there was like Friday, Saturday night. So you would see me swing up with that. So, but I think it's just when the most people are the most active would be my guess. Then looking at some of, as far as our response time, I did some averages And then also looked at like how much time we spent on time on scene in fractiles. So looking at where like the 25 to 30, we're off scene in less than 30 minutes 95% of the time. So that goes sometimes 3% of the time in less than 5 minutes that we're there. And then how long it's taking us to en route till we're on scene. So most of the time we're less than 15 minutes. So again, it all varies on where. Most of our responses are emergent, with some of them being non-emergent. Then the bulk of what we do when we do transport is non-emergent without lights and sirens. So, which is good and safer as well. Then also try to present a little bit of clinical data. My goal is to try to present a little bit more moving forward. So having some things with outcomes, because at least this is my opinion, most people care more about did they survive things versus how fast did we actually get there. So looking at some more of those things and how we're doing and meeting national standards with things like the use of aspirin with somebody having a heart attack, that type of stuff is a goal I'd like to add. But looking at our top kind of 10, the complaints reported by dispatch, and then the top 10 complaints, this is the provider diagnosis is on that one. That's all right. The next page, there you go. So the top one with that is that this is what my guys have said, what they think is going on. So they have to give their, in a way, like a presumptive type of diagnosis. So most of what we have there we do quite a bit of falls as far as responses. But we have a relatively, like the next slide shows that the bulk of the patients that we do, 63% are over the age of 60. So most of the population that we see is older. And then some of these about medications, we do a lot of pain medication is the fentanyl, and then the ondansetron is a anti-nausea medication, and then followed up by respiratory, and then aspirin. So these are kind of like the big things as far as treatment wise. So I wanted to give a little of that. I was able to pull some data looking at how we've done with cardiac arrest, and that's the next little bit there. Like last year, we had 73 cardiac arrests, with 58 of them that we attempted resuscitation, and we got a return to spontaneous circulation on 14 of them. And the way where it says suppressed, this is because there's not enough data that's there, that numbers that still could be skewed. Like if they can only get 2 reports and one of them, didn't make it, and the other one did, it shows only 50% success rate. So the way that this piece of software works is if it's not a sufficient number, it doesn't report it. So that doesn't give skewed kind of data with it. It isn't anything I did. The state of Montana has it. It's a program called Biospatial. That's a part of it's linked with our image trend stuff. So that's where I got that from. So I don't have control over changing that. And then some of these working on very much. Thank you very much for sharing that. One of the things like quality improvement is a big important goal of mine. So looking, at us as a system and how can we improve? Because the only way you can improve is we got to see where we sit as far as how we operate, and then using that data to look at our system and how can we improve our system. Because it's rarely ever people trying to do a bad job. Your system's perfectly designed to get the results it gets. So if we want to change those results, we need to improve the system. So those are the things that I would like to look at, is developing our quality improvement. So, and probably not all at once, take some bites of the elephant at a time and pick some chunks and focus on some big things. Myocardial infarctions and heart attacks, and look at those, and are we doing the things that standard practice, and then improving like that. One of the big ones we're doing right now is traumatic brain injury, because that's a focus with the Department of Health and Human Services. Is traumatic brain injury, because of our numbers in Montana are not good. So how can we improve that in the care with traumatic brain injury? So that's the first quality improvement project we're going to be kicking off with. So hopefully next year I can report during the data how how we looked in the past, and then what improvements we're making moving forward as far as the clinical care for patients.
Awesome, thank you.
Mhm.
Any questions?
I have a question.
I have a question.
Mr. Chairman, I got a question. I don't think they can hear me.
Really? Never mind.
I have a question. Why do you think traumatic brain injuries are so poor in, or the number of them are so high in Montana?
Well, what I can gather, so I'll explain, I'm new to Montana, I just moved here. Thank you.
Yeah,
I'm here from Colorado.
Did you come in on a jet too?
No, I drove in.
Oh,
Drove in. I have flown in here. My father-in-law's lived up here for the last 10 years. So I had a big draw while we moved up here. But so I can't say some of the stuff, most of my EMS career is Colorado. But what I've gathered looking at data and the things that I can find, I mean, there's a number of things that play into it. I think that there's a higher prevalence of alcohol and the use of things with like motor vehicles and motorized type of stuff. People spend a lot of time outdoors doing outdoor activities, climbing, those kind of things where there's a little bit of a higher chance. I don't know how to phrase this without sounding political, but without the regulations on safety kind of stuff, that you have people that do some of these things without having some of that stuff in place.
Yeah.
And then being a large state that has a small population, that the healthcare system is mostly rural, and you've got a lot of critical access type of stuff. So the time delay from initial insult to where they have definitive care, there's a little bit of a delay, can be especially that pre-hospital transport side of things. I think we can play a big part in that. I mean, because there's the preventative things to try to like make awareness in doing that. But from the time of insult to the time of arrival at the hospital, that I think there's a number of things that especially us in the pre-hospital world that we can focus on. And that's some of the big things where the state has listed. And if we do a number of those, we can help make a difference in the outcomes of some of these. Some of them are catastrophic, and it doesn't matter where you are. You can pick the biggest city in the country and be downtown next to the biggest trauma center, and you're not going to make a change in the outcome. But those ones that are in that in between, I think we can make a big difference from a pre-hospital standpoint. And a lot of that is just education. Things are slow to change with like the pre-hospital standards of care, and it's across the country. It isn't just Montana; it's everywhere. Where in moving on, what's more scientifically appropriate, looking at research. So I think that right now is a big push, because some of the evidence that's there has been around for over a decade. But I can tell you, with my interactions with things around the country, I would say maybe a quarter of the country, the hospital is truly functioning at that type of level. But I think because of the state, the size, the distance from some of the care, and those things play a big part.
Any other questions?
I have a couple from our online viewers.
Awesome.
I've got a question. Can you hear me all right?
Definitely. I think I hear him. Why can't you hear him? Technical difficulty.
Hey, John, can you hear me?
Hard work on that. Definitely on this day. Chris has already been a really welcome addition. He's worked with us in the fire department, talking about integrating our quality assurance, quality improvement process, and the ability to follow through with patient outcomes. As a non-transporting element to emergency services, we don't always get that perspective of how things end up turning out. And Chris is already a good partner in helping us facilitate those discussions. So
We're trying to do that with all of the departments. That's the one way we can't get better unless we know how the things we're doing and understand. So that's a goal of mine as well. I want to work with everybody, improve that feedback, improve the education and training.
While we're waiting, could I ask a couple of questions? Sorry to join you late, first of all. My apologies for that. I'm Roger.
Hello.
Nice to
Chris.
meet you.
Nice to meet you.
Welcome to Montana.
Thank you.
I was just looking at the report from a couple of years ago, and it said that you had a total of 10 ambulances,
Mhm.
but only 6 were what you consider to be frontline to be used for 911. Is that still the status of what you all have?
Still at 10. I can field 9 that are stocked. With a couple of them that are relatively old, that they're like kind of deep reserve.
Mhm.
From a staff standpoint, with them right now, 4 generally per day are on the street. If we, depending on the staffing, there are certain days I try to make a manager kind of truck to help out with, the volume, and I love being a paramedic, so being able to have the opportunity to play too. So going out and doing that. So occasionally having a 5th. But if right now, if like we had something big happen, I could potentially put 9 ambulances at that event.
Oh, okay, thanks. A couple of years ago, there was this program called the Community Paramedic Program.
Yes, sir.
Does that still exist?
I can speak to that.
Yeah, and we'll be the
Oh,
So it exists until the end of. So that was a grant funded program that our grant funding has run out. And with the current financial climate, we were unfortunately unable to continue that program. And so we have sunset that program. They will finish up with their clients and then transition out. We have a couple of folks from that program that are looking, because they are licensed EMTs, paramedics, at coming back possibly to.
Is my mic working? Apparently not.
Sheriff, it's on their end. It's not on ours. I can hear you
Okay.
fine.
All right, thank you. Glad I didn't start feeling embarrassing.
Hear us now?
We can hear you. Can you- We can hear you.
I'm just using the chat right now, Sheriff.
Okay,
I don't think it's working. So I'd say if you put your chat to hosts and panelists, you can type in there.
yeah, I did earlier.
Pam, can you hear us? There. Turn towards the microphone. Can you hear me?
Yeah, we can hear you now. Can you hear us?
Does anyone online have a question or comments on the presentation?
You had a question? The sheriff that was asked, who does the preventive maintenance for the ambulance service?
The Chevy dealer is who works on the vehicles. Well, if there's something specific as far as with the box, then we work with the manufacturer.
Part of the report shows the basic city meetings is there a better breakdown of the district?
What would you mean by district? I don't know.
We can break them down by geographical zone. Is that? Are there things in the report that you would like to see? Differently, is there anything from the operation standpoint that? Not that we like to know?
And typically a portion of our district is telemed. We're plus medical calls last year. Including this value.
Should, yeah, we have that.
The way to put some of the data together, I didn't know what was expected as far as I did it by city, because that was a very easy way, that was already a pretty good plan. It was there. But yeah, I could definitely break it down for you.
By, oh, which interviews are utilizing?
I could offer up on something. I don't know if this may be what they're referring to, but you're welcome to this if you might want to use it. Looks like in the past it was broken down by fire district, about the 28 zones of the city.
And that would like to, what is the preventive maintenance schedule for grants?
As far as the, I know that work with, don't have, to be honest, I don't have a complete answer for it. It's many things on my list that work with Chevy to find out what they do as far as preventive maintenance. Because that we the three different types depending on where it was in mileage. So that we basically call it agency. At a level, which would do an oil change, quick check of things, B was a little bit further deeper down, and then C was the once a year big type of stuff. Where I came from one of these is like we change batteries every year, because handles is not to use batteries. At best you get about 18 months out of batteries in handguns. And so somewhere between 12 and 18 months they die, and the worst places to have them die when you're on call. And I was nice that I wasn't that far outside of Denver that I could get somebody relatively quickly before we're on the top of the pass and dump batteries. That's going to be a bad spot. So I would like to, I don't know if we have those papers, we did that with Texas as well. And sometimes change from the weather to the airguards. And so I need to get a better handle on it. I don't have a great answer for you at the moment. I've been tackling lots of things. It's on my list to tackle. I very much agree that the preventive maintenance is a huge important thing that we never schedule. And I want to know what they're looking at and then we're trying to do those things. Those ones
Currently, Dave Webster, previous manager over the department, is still managing our fleet. So he has a lot of information that's still that should be pretty standard from what it's done in the past. We're increasing community platform. I think I
Walk over there. Are they answering your question, Sam?
don't, maybe they can't hear our answer.
Can y'all hear me? In the room, you can hear me? If you're saying yeah, say it louder, because I can't tell.
I can hear you.
Okay. I'm just wondering, so do the results of the report have any bearing on planning by St. Peter's Ambulance when it comes to scheduling and staging resources?
Yeah, so one of the things we're doing right now, actually, with making sure that our team is involved as well, is we have a kind of rapid process improvement project going on with our staffing and scheduling too, so that our staff understands as well. Our teams, we just reviewed all of the data for 2024. and broke it down by zone for them, the type of call, ALS versus BLS, the response, so that we can make sure that we're staffing and stationing our ambulances appropriately. One of the other things that we have had to do this month is due to the call volume, our staffing and our financial situation, we did let go of our lease of our police station. We no longer have, we have not had a truck station out there for some time just due to staffing. And when we look at the majority of our call volume, it is within the city of Helena and then north. There is some out in East Valley, but not enough to justify a full station and a full crew being out there. So we did let go of that lease and at the end of June as well. And so we are working with our staff to ensure that we
was asked, what was the cost of that lease?
$1,600 a month.
Can you hear me?
I think it might be easier just to mute them and we haven't put any other questions or comments in chat. Or just keep typing it.
Mike, yes. My question for you is who does your preventative maintenance and what's your program look like on the ambulances? Can you hear him, Sam?
I heard you, Sheriff.
By the time I walked over there and growled, I think they'd all be gone.
It would be. Yeah. Would be.
Sheriff, I put your question in the webinar chat. They
Okay,
answered. They can hear you now.
okay. Who does your preventative, Chevrolet of Helena does the maintenance, okay? Yeah, what I'm saying in preventative maintenance, that's fine, is that, I'm trying to differentiate between chronic and acute. What, the reason you don't have acute issues with, say, critical failures, who does that? Who makes sure that the tires are rotated X amount, oil changes are X amount, time limited parts are changed out so you don't have critical failures? I didn't see that, so help me out if you can hear me.
Sir, just all of that. Schedule. For all that, so.
Jeffy does all of the work, the preventative maintenance. We're gonna be working on improving the program with the addition of the Freedio software. We're gonna have a better handle on our preventative maintenance.
Thank you. If I smile, does it help?
Yes.
Any other questions or comments? Do you have any public commentary? Moving on. Just in update on some information relative to the contract and bylaws. The contract, runs through May 1st of 2027. So for next year, we should anticipate so just some discussion about how we're gonna plan for the renewal contract and whatever other renegotiation elements need to be brought up. For giving us a 2-year window, that should be substantial time to have a well thought out process. Relative to the bylaws and the MOU, if that's the right term that came around last time, only bring those up, they're complete. But the city's moving into what we're calling the M-file system, and it's a workflow methodology that should improve how contracts flow from the department that originates them or negotiates them to the city attorney's office for review to the city manager's office for finalization and approval. So we're still working on the workflow side of that. Some departments are using it very regularly. The workflow side on the fire side is still being developed in progress, but that'll be a routing methodology. So a lot of that should be encapsulated in an electronic version. We'll have opportunities to meet and discuss the content of that contract before it's reviewed by the board. Any questions or comments for election of vice chair? It's in the bylaws. So far, it's been a pretty low impact position, but nonetheless, it continues to exist. So, any nominations for vice chair? Vice chair,
This is my first meeting, so I'm just along for the ride.
So, any discussion? All in favor of the sheriff as vice chair, say aye. Aye.
Aye.
Aye, whatever we're voting on, aye.
You just got voluntold.
You know, this is the case in the where you should get your butt over to the meeting and be in place and not on this thing. Who knows what the hell I volunteered for?
Do we want to set the date of the next meeting, or should we do the same kind of process and feel like the schedule is the big approach? Is it? I think that works. I think everybody's busy. The bylaws tell us April is our target, but it's not uncommon. I think it comes in May, and it's even been in that, particularly when we don't have a contract to review specifically. I think that timeline is probably something that everybody can achieve. Anybody with any additional elements or proposals for the next agenda? Any final public comment?
Thank you for trying. I'll be there in person next time. Bless the hearts.
All right. Right. You just.
We got numbers and stats and everything.
And done in less than 40 minutes.
Oh, right.
You know, it's never one.
Not if it's only because I'm sick. I want to be able to. Yeah. I mean, how, make a difference with patients.
Yeah.
That.